What can pharmacists contribute to the management of delirium?
We should all be aware of delirium. We don't really even need to be a health professional to be aware of it generally, because it is very distressing for our patients and for those who care for them. Pharmacists, I'll start with those in the ICU, shall I, and I'll cascade down. So pharmacists in the ICU should be aware that as I said, when we ventilate patients and we sedate them, we give them sedation and opioids. And there is reasonable evidence that suggests that the more sedative an opioid we give to the patient, the greater the risk of delirium later. So we should be there at the bedside every day, ensuring that the doses are right for that patient and they are regularly reviewed. And that's part of our medicines optimization schedule, isn't it? It's even more complicated in ICU, of course, as many of these patients have got multiple organ failure. Their kidneys don't work, their livers don't work properly. And of course, that's how we metabolize and eliminate drugs. So the pharmacist should be there, understanding the drug, understanding the sedative, and understanding the antimicrobial even, because very high doses of them can cause delirium in the context of that patient and using the therapy effectively. They should be at the other side, questioning therapy that is of limited benefit. For example, long courses of antipsychotics. Fair enough, giving the patients agitated, as I say, but long courses within the ICU should really be discouraged. And when patients, when they drop down from ICU to other areas of care, we should be reviewing their prescriptions and ensuring these patients don't continue on that therapy long term. As well as all that, which is our professional role, we should also be talking to our patients, even when they're acutely unwell. Because remember, this orientation in time and place is very important. Of course, someone's on a very high concentration of oxygen and they're deeply sedated, they're too unwell. But as they're coming round, as they're being rehabilitation, I always encourage my pharmacy colleagues to introduce themselves to the patients. This stimulation is actually quite important. And then from the ICU down to the medical wards, again, it's about medicines optimization. Reducing and stopping therapies that were started in the ICU that were deliriogenic in the longer term, orientating our patients in time and place, reducing their anticholinergic burden. And this might be a good time for the pharmacist to look at the patient's long-term medicines and perhaps talk to the patient about those ones that are likely to have an increased anticholinergic burden in the longer term and change or, optimize their therapy. I think those of us who work in secondary care recognize the lack of time the pharmacist, even in the GP surgery, has to spend with each patient and do all this, nuancing medicines optimization. We should be doing that. On the discharge and during the discharge process, again, it's about, this continuation of care. We all recognize how different it is in the medicine safety risk, but there is this risk of continuing long-term therapy. So patient may come in and be in pain, of course, in the ICU, having a major surgery, but that doesn't mean they should go home on a long-term opioid, which will increase the risk of delirium. So making sure the medicines are appropriate for the patient.
So that's in hospital. What about in the community?
And then in the community setting, there's a huge role. And I believe some colleagues are campaigning actively. I think oxybutynin, which I said has got very high anticholinergic burden, is going to be available over the counter, which is a good or bad thing. So I think pharmacists should be aware of the risks of this drug causes in terms of triggering dementia, as I said, long-term exposure, certainly increasing the risk of delirium. So it's about properly counselling the patient, and in a very elderly patient, perhaps recommending another therapy, or persuading them gently to take another therapy, or looking at the medicines they're on and encouraging them, reviewing the medicines on and seeing if this medicine introduced will increase their burden or their deliriogenic potential long term. I'd like to say encourage them to give thiamine, but of course that's not evidence-based medicine yet, because we don't really have the evidence. But actually, if we know the patient is alcohol dependent, checking that they are on long-term therapy, long-term thiamine will reduce their delirium, but that's alcohol-associated delirium, which is called Wernicke's.
A lot of useful pointers there. Do you have anything else to add?
So, although I think I would just encourage perhaps colleagues in the community setting to remember about this acute confusion. I know most of them know, but remember that acute confusion in an elderly patient can be a trigger for another pathophysiological change. And so your intervention at that early stage is very important, and swifter intervention reduces the risk of cognitive decline in that patient. So it really can transform someone's life.
And my last question, what would you say to a young pharmacist who was wondering whether intensive care is a worthwhile specialty to go into?
Don't hesitate. I'd say it's a great specialty to go into, particularly if you love, it's not so much science, because all areas of pharmacy are science driven. I think the thing that we do in ICU, which I love, is, as well as using our evidence, we take the drugs back to their first principles a lot, so we have to understand the drug properties, its pharmacokinetic properties, and how it is dosed within that patient. And we do that on a daily basis. So if you're passionate about keeping that side of your pharmacokinetic brain alive, it's a specialty for you. And actually, we're a real multidisciplinary team. We work very well together, and I think it's a huge area for pharmacists. Huge number of, I don't say huge, but a large number of consultant pharmacists, a number of us have PhDs, lots of opportunities to research. So don't hesitate.
Dr. Cathrine McKenzie, thank you very much for sharing your insights and experience with us today. That really has been inspiring. For more information about Dr. McKenzie's work, please visit our website using the links in the description. And be sure to sign up for more news, videos and journals. For updates straight to your inbox, please follow the links below. And thanks for watching.